So in the context of other targeted therapies, the reason that we're really improving prognosis is that people have simultaneously studied what causes resistance and developed new therapies for next line therapies. And in some contexts, we've even actually leapfrogged the older therapies by using the next line more potent therapies, such as an ALK and EGFR. So what do we know about resistance to kind of BRAF combination therapies? I think the key point is that although we've known about BRAF for a while, what we know about resistance is, to be honest, a little bit rudimentary compared to kind of the depth of what we know about resistance for other targets. We do know that the cancer really doubles down on that MEK signaling cascade. It finds ways to make the cancer dependent on RAS or dependent on or turn on that downstream signal MEK. And so what people have seen is that there's a variety of KRAS, NRAS, and other RAS mutations that make the cancer dependent on not just kind of that single BRAF protein for signaling, but a dimer complex that involves BRAF and CRAF. And you see in that context, it's not helpful to just block BRAF. They've also seen mutations that activate MEK downstream to make it such that trametinib cannot bind. And so that has informed kind of the design of ongoing studies and newer therapies, including pan-RAF inhibitors that can block both BRAF and CRAF and can also block dimers, not just monomers. And also combining these pan-RAF inhibitors with newer MEK inhibitors or ERK inhibitors, that key signal downstream of MEK. And I do want to point out that I focused on dabrafenib and trametinib because those are approved in non-small cell lung cancer, but there are other kind of BRAF MEK combinations, including vemurafenib and cobimetinib that's approved in melanoma, and another one that's making its way through phase 2 testing in non-small cell lung cancer called encorafenib and binimetinib that we are eagerly awaiting results for because that one is already approved in melanoma and colon cancer. So next slide. And so I had mentioned at the beginning that the whole story is not V600 mutations, right? There are other classes of mutations, and it would be great if we could just repurpose our existing therapies for all BRAF mutations, but it seems like that will not be the case. As we already saw from that study that I presented of vemurafenib, the response rate to a BRAF monomer inhibitor was 0% for these class 2 and class 3 mutations that signal as dimers. What happens is that if you just block one part of the dimer, the other one becomes hyperactivated and you actually get way more signaling through MEK and ERK. But the story isn't as kind of dismal when you do talk about MEK plus BRAF combinations or MEK inhibition by itself. Turns out that in the lab, there are certain BRAF mutations, particularly these class 2 ones that are already activated, that can benefit from blocking BRAF and MEK. Next slide. And that has actually borne out in the clinic in case reports. And so the first case report was published by Negrao and McCoach and colleagues, where it describes kind of the benefit from dabrafenib and trametinib, that approved BRAF MEK combination that's only approved for V600 BRAF mutations. They basically gave it to a patient who had a class 2 L597R BRAF mutation. And as you see here, there's a response in the lung lasting over a year. Another case I wanted to highlight is a patient of mine who had a G469A, which is perhaps the most common class 2 BRAF mutation, and also benefited from dabrafenib and trametinib, so that BRAF MEK blockade, as we can see here with shrinkage of a liver lesion, and this response lasted about 6 months. I should note that at the beginning, we're focusing a lot on mutations, but at the beginning, I did mention that BRAF can be activated by fusions. These fusions are probably kind of most important in the context of blocking other targets, such as EGFR. I just want to note that the combo of BRAF and MEK inhibitor is actually efficacious or has good activity in that context as well. So adding that to the backbone of EGFR targeted therapy in case reports, but as you can imagine, toxicity can be quite substantial. Next slide. And so to summarize kind of what we've talked about, I think it's key to mention that when we talk about BRAF mutant non-small cell lung cancer, we're still scratching the surface in terms of the functional consequences and also finding efficacious therapies. We have good therapies for BRAF V600 mutant non-small cell lung cancer. And so one key point I want to remind all of us is that BRAF altered non-small cell lung cancer encompasses diverse alterations, and there are 3 main strategies that are used to activate downstream signaling. And that matters when you're trying to think about the therapy to use. For dabrafenib and trametinib, the therapy that we have currently approved is only for class 1 or V600 BRAF mutations. And what we know about resistance to this combination suggests that the cancer really wants to find a way to reactivate MAPK signaling, often at the hands of a new RAS mutation. And in this context, it's not, the strategy that might make the most sense is kind of something that blocks both CRAF and BRAF. Another thing to note is that where are we going in the future, right? The future is really focused on non-V600 BRAF mutations, and there have been novel kind of preclinical studies that have demonstrated encouraging efficacy. These are therapies that block pan-RAF, as I mentioned, BRAF and CRAF, but are also kind of getting away from the historical principle of only blocking monomers or the single BRAF mutation protein and going towards dimers. These are dimer breakers or dimer inhibitors. And then there's a class of therapies that I didn't have a chance to talk about called SHP2 inhibitors that are particularly efficacious in the preclinical setting for those class 3 mutations that are dependent on RAS, because SHP2 is it crosstalks or talks closely or communicates closely with RAS. And so this is a space to keep an eye out on. I think that we will have multiple kind of new promising clinical trials in this space in the future.